Good morning, students. Let us start our lecture. Today we start the section drugs affecting the functions of the effectory organs and system. The first lecture is devoted to agents affecting the functions of the respiratory system. These drugs include following: drugs eliminating bronchial obstruction, drugs used for treatment of acute respiratory insufficiency, breathing stimulants or analeptics, and drugs inhibiting cough reflex, antitussive, and promoting production and discharge of sputum, expectorants. So, eliminating bronchial obstruction, used for treatment of acute respiratory insufficiency, breathing stimulants, and antitussives, expectorants. First of all, about bronchial asthma. Bronchial asthma is allergic disease. This is sample of allergic reaction of immediate type. The essence of the disease is narrowing of bronchi. Narrowing of bronchi. If you see, these are normal airways. These are asthmatic airways. And this is asthmatic airways during the attack. During the attack. Attack is associated with the entrance into the organism of specific molecules, allergic molecules. If first in the organism immunoglobulin E developed to this chemical structure, so after every introduction, every entrance of this molecule into the organism will cause acute allergic reaction, because allergic molecules interact with specific immunoglobulins E. These immunoglobulins localized on mast cells or tissue basophils. That is why interaction between allergic molecule and immunoglobulin E causes release, discharge from mast cells of the group of molecules which we call allergy mediators. The basic substance is histamine and so on, and so on. So histamine and other substances, leukotrienes and so on, cause contraction of bronchial smooth muscle. This is first reason of bronchial obstruction. And second, allergic inflammation of mucosa. It means edema of mucosa and hypersecretion, first of all. That is why there are two reasons of bronchoobstruction. Bronchospasm 1, and edema and hypersecretion of mucosa 2. That is why, while treating patients with bronchial asthma, we should influence on both, on smooth muscles and on bronchial mucosa. Bronchial mucosa. Drugs eliminating bronchoobstruction include drugs eliminating bronchospasm 1. We see three groups by the mechanism of action in bronchiolytics. Agonists of beta-2 adrenoceptors of bronchi, blockers of M-cholineceptors of bronchi, and phosphodiesterase inhibitors or myotropic bronchiolytics. What is the essence of action of these drugs? We need a relaxation of smooth muscles to dilate bronchi. tonicity of smooth muscle, of any smooth muscle, depends on calcium concentration inside the smooth muscle cell. Calcium concentration. The more calcium, the more contractility. So we need to decrease calcium concentration within the smooth muscle cells. It's possible by influencing via innervation, first and second group. First group acts via sympathetic innervation, second group via parasympathetic vagus nerve. So the drugs act via innervation and via receptors for sympathetic and parasympathetic neurotransmitters. And also it's possible to influence smooth muscle cells directly. The agents penetrate through the cell membranes of smooth muscle cells and act directly on these cells. We call myotropic bronchiolytics. Myotropic, it means agents acting directly on smooth muscle cells. How is stimulation of beta-2 adrenoceptors associated with decrease of calcium? The agents stimulating adrenergic receptors in bronchi, there are beta-2 adrenoceptors localized. In stimulation of these receptors, first of all, specific G protein is released that leads to activation of special enzyme adenylate cyclase. This enzyme causes accumulation of cyclic adenosine monophosphate. And accumulation of cyclic adenosine monophosphate stimulates different calcium-dependent processes in smooth muscle cell that leads to decrease of free calcium concentration. Once again, stimulation of beta-2 receptors localized on cell membrane, postsynaptic membrane, causes release of specific G protein, activating G protein, that causes activation of enzyme adenylate cyclase, that causes accumulation of CAMP, that causes to decrease of calcium concentration within smooth muscle cells. Parasympathetic nerve, vagus nerve, innervating bronchial smooth muscle, releases acetylcholine. So acetylcholine released from presynaptic membrane interacts with M cholineceptors localized on postsynaptic membrane that causes, on the contrary, increase of tonicity. That is why if we need to relax smooth muscle, we should use antagonists of M cholineceptors. We should block influence of acetylcholine on M cholineceptors. That's why we use M cholinoblockers, M anticholinergics. So we use M anticholinergics. They block M cholineceptors that prevents influence of acetylcholine on M cholineceptors and prevents increase of contractility. The mechanism is associated also with specific G protein. Acetylcholine, unlike norepinephrine, noradrenaline, acetylcholine stimulates cholinereceptors that causes specific G protein activating guanylate cyclase. Guanylate cyclase, this is enzyme promoting synthesis of cGMP. But cGMP, increase of concentration, promotes increase of calcium and promote contraction. Blockade of M cholineceptors causes decrease of cGMP. That's why decrease of calcium. So we need or increase of CAMP inside the smooth muscle cell or decrease of cGMP. And first group, agonists of beta-2 adrenoceptors, increase CAMP and via this mechanism cause decrease of calcium. Second group, decrease cGMP concentration and via this mechanism causes decrease of calcium. How do myotropic bronchiolytics act? Molecules of these drugs penetrate exactly inside the smooth muscle cell, penetrate through the cell membrane and interact with specific enzyme phosphodiesterase inside the smooth muscle cells. Phosphodiesterase is enzyme cleaving CAMP. CAMP is synthesized because of activation of adenylate cyclase, but after is cleft by phosphodiesterase. If we need increase of CAMP, we need activation of adenylate cyclase or inhibition of enzyme phosphodiesterase cleaving CAMP. That is why we see that first group acts via increase of CAMP and third mechanism acts via increase of CAMP. But second group drugs act via decrease of cGMP. Decrease of cGMP. And now more precisely. Agonists of beta-2 adrenoceptors of bronchi. Historically, they include several groups, from least specific to most specific. All the drugs are less specific. New drugs, later drugs, are more specific. The least specific agents are sympathomimetics, including ephedrine, phenylpropanolamine. Sympathomimetics means agents acting upon sympathetic nerves, causing activation of release of norepinephrine. And via increase of release of norepinephrine, they increase influence of sympathetic nerves on all organs, including, of course, bronchi. That's why we understand that this is the least specific, because the drugs act not only on bronchi, but on all the rest organs. That is why they can cause different unfavorable effects. Second subgroup, alpha-beta adrenomimetics, epinephrine. This is preparation of adrenaline. Adrenaline belongs to alpha-beta adrenomimetics. It means the agent stimulates both alpha and beta adrenoceptors. More precisely, alpha-1, alpha-2, beta-1, beta-2, beta-3. So epinephrine is non-specific adrenomimetic. It stimulates all of kinds of adrenoceptors. And comparatively, epinephrine acts more on beta adrenoceptors than on alpha. We need in bronchial asthma exactly stimulation of beta-2, but stimulation of beta-1, beta-3 will cause side effects, and stimulation of alpha also will cause side effect. Alpha adrenomimetic effect, this is increase of arterial pressure. For what do we need increase of arterial pressure? But the drug causes. The drug causes stimulation of heart activity, increase of heart rate, increase of contractility, provokes tachycardia and cardiac arrhythmias, and also attacks of angina pectoris. But epinephrine is very strong broncholytics. When we didn't have more specific drugs, of course, we used epinephrine. And nowadays, we use epinephrine, but only sometimes if more specific drugs are not helpful. Come on. After appeared adrenomimetics without alpha adrenostimulation activity. Beta adrenomimetics, only beta. We understand that beta adrenomimetics can't stimulate alpha, that's why they don't cause increase of arterial pressure. It's very good. It's very good property in comparison with alpha-beta mimetics and sympathomimetics. But we see isoprenaline and orsiprenaline stimulating both beta-1 and beta-2 receptors also can cause non-necessary stimulation of heart because of stimulation of beta-1. Once again, we need stimulation only beta-2 with bronchial asthma. But the drugs will cause bronchodilation, but at the same time tachycardia, and can provoke cardiac arrhythmias and so on. But these drugs are more specific than epinephrine. And after appeared the group of selective beta-2 adrenomimetics. And nowadays, this group is the most specific, is the best to treat bronchial asthma. Selective beta-2 adrenomimetics. We understand that they don't stimulate alpha, they don't stimulate beta-1, that's why don't cause no arterial hypertension, neither tachycardia, but only dilate bronchi. Only dilate bronchi because of relaxation of smooth muscle cells. First appeared the drugs salbutamol, phenterol, terbutaline, hexoprenaline. When we used only these drugs, we didn't call them short action duration. Of course, we knew that the drugs act for 4 to 6 hours. First, we started to use them in the form of tablets for oral introduction, in the form of solutions for injections. But after, we discovered that these drugs are very effective in inhalation introduction. Inhalation. And that is why, since these years and nowadays, we use all these drugs, selective beta-2 adrenomimetics, only in the drug form for inhalation. These are or aerosols or sprays. A patient puffs, inhales once or twice, and the drug acts. These drugs act for 4 to 6 hours, but of greatest importance, they start to act in 1 to 2 minutes after inhalation. That is why, of course, we started to use these drugs to stop acute attack of bronchial asthma. Once again, because onset is very fast. But action is over after 5 to 6 hours. And in severe asthma, of course, it's necessary to use again. That is why these drugs can be used 3 to 4 times daily, not more. It's prohibited to use more. If you will use more often, it can cause opposite reaction. The drug can provoke more bronchoconstriction. That is why only 3 to 4 times. 3 to 4 times. After several years appeared the drugs with the same mechanism but long action duration. Formoterol, clenbuterol, salmeterol. Also we used and nowadays use in the form of inhalation, and one inhalation acts within 10 to 12 hours. 10 to 12 hours. That is why, comparatively to first group, it's possible to use these drugs once or twice daily. But as for onset, clenbuterol and salmeterol act in 20, 25, 30 minutes. It's impossible to use to stop acute attack. But formoterol acts also fast, like the agents from the first subgroup. It acts in a few minutes. 1, 2, 3 minutes and attack is over. That is why nowadays formoterol is one of the most popular agents, because we can use for both and for stop of attack of bronchial asthma and for prevention of attack. But these drugs of the first subgroup we also can use both to stop attack, to prevent attacks. But it's necessary to use them or more often. But formoterol, sometimes it's enough 1 time daily, 2 times daily to control patient's condition. And several years ago, within 8 to 10 years, appeared the agents with the longest action duration for this day, because we don't know what will be in 5 years and 10 years and so on. So appeared the drugs indacaterol, bambuterol, olodaterol, and vilanterol. One inhalation of each causes effect for 24 hours. For 24 hours. Only one inhalation and prevention of attacks for day and night. But no one of these drugs acts fast. Action developed in 1 to 2 hours. That is why these drugs are not available to stop attack, but are very effective and very good to control bronchial asthma during the whole day and night. So, nowadays, to treat bronchial asthma, more often we use this group of drugs, agonists of beta-2 adrenoceptors of bronchi. Which drugs exactly? To stop attack, we use short-acting agents or formoterol. To prevent attacks, we can use all of them. Sorry. But it's better, of course, to use the agents with longest action duration. That is why more often nowadays we use third group or second group for prevention. And what can we say about isoprenaline or sertraline? maybe no need to memorize these drugs because we have more specific, more selective beta-2 mimetics. No need to forget these drugs, isoprenaline or seprenaline. For example, a patient suffering from bronchial asthma has accompanying heart diseases, bradycardia, or for example, atrioventricular block, AV block. And we need at the same time and relax bronchial smooth muscle, but to stimulate cardiac receptors. And in this situation, the best drugs are isoprenaline or seprenaline. And we will use these drugs. We should know that selectivity of beta-2 adrenergic receptors is relevant. In therapeutic doses, yes, they are selective beta-2 adrenomimetics. But in high doses, they also can stimulate heart in high doses. That's why it's necessary to control dosing very thoroughly. And also in high doses, these drugs can penetrate through hematoencephalic barrier, and the agents possess activating influence on the CNS. That's why we should use 1 or 2 inhalations, 1 or 2 puffs only. So isoprenaline or seprenaline, no need to forget, because we can use in bronchial asthma accompanied by bradycardia or AV block. And epinephrine nowadays, epinephrine. If attack is very severe and we use beta-2 adrenomimetics and can't help to the patient, we use epinephrine. Epinephrine is more potent broncholytic than all the rest. So in severe attacks, we are forced to use epinephrine independently on different side effects. As for ephedrine, phenylpropanolamine, they are used rarely nowadays, not in real bronchial asthma, more often with bronchitis on the background of increased tonicity of bronchial smooth muscle. Next group, blockers of M. cholinesterase. We distinguish drugs with general action, traditional drugs, atropine, metacinium, platyphylline. These drugs can be introduced or orally in the form of tablets or by injections. And after introduction, the drugs act on the whole organism, not selectively. Not only on bronchi, on the heart, on stomach, and so on. The drugs with general action. And the agents with local action, historically second generation drugs. These are derivatives of atropine and like atropine preparations, but if atropine has high bioavailability, penetrates well through different membranes, these agents, first of them is ipratropium bromide, are worse penetrate. That is why these agents are used in the form of aerosol or spray. A patient inhales also once or twice. And agent acts only upon bronchial mucosa and smooth muscle. That is why these agents with local action are more specific, because they don't cause systemic action, don't cause different side effects. What side effects? For example, hypersalivation, tachycardia, increase of secretion of gastric juice with hydrochloric acid, stimulation of peristalsis of GIT, and so on, and so on. Sorry, decrease of secretion of gastric juice, decrease of peristalsis, and also impairment of vision. Impairment of vision. These drugs, using in the form of inhalation, don't cause these side effects. That is why nowadays we use exactly agents with local action, ipratropium, but this is older drug. It acts for 8 hours and it's necessary to use 2-3 times daily. Tiotropium, umeclidinium, glycopyrronium, and eclidinium, acting for 24 hours. That is why more popular nowadays exactly these drugs acting for the whole day and night. Comparatively, broncholytic activity of beta-2 adrenomimetics and local M-cholinoblockers, comparatively, activity is a little different. More active are beta-2 adrenomimetics, more active. But M-anticholinergics, besides influence on smooth muscle, also influence on mucosa. They decrease secretion of sputum. This is very positive mechanism for bronchial asthma. That is why topical M-anticholinergics are used not so rarely. So this is second group. And the third group, myotropic bronchiolytics or phosphodiesterase inhibitors, acting directly on smooth muscle cell. These are theophylline preparations. The basic agent is theophylline. Theophylline penetrates through the membrane of smooth muscle cell and within smooth muscle cell interacts with the phosphodiesterase, inhibits this enzyme that leads to accumulation of CAMP, and that is why to decrease of calcium concentration and relaxation of smooth muscle. But theophylline, besides bronchiolytic action, causes stimulation of heart activity. It increases contractility of heart and also causes non-specific stimulation of CNS activity. That is why it's necessary to be very attentive and strictly follow the dosing of preparation. Theophylline itself is used only orally because it is not water soluble. But preparations of theophylline, for example, euphylline or aminophylline, this is preparation of theophylline which is water soluble, and it is produced in both forms, in the form of tablets for oral introduction and in the form of solution in ampules for injection. Intramuscular and intravenous injection are used to stop attack of bronchial asthma, but tablets are used to prevent attacks. The drug, theophylline, aminophylline, choline theophyllinate, doxyphylline act within 6 to 7 to 8 hours within. And nowadays we have retard preparations, long-acting preparations of theophylline, acting within 18, 20, and 24 hours. The names are Theobilong, Theodur, Theopec, Retafil, Theotar, Durofilin. But the agent in this preparation is theophylline. These drugs are specific preparations with prolonged release from the drug form of the agent. So, to stop attack of bronchial asthma, we can use short-acting beta-2 adrenomimetics or beta-2 adrenomimetic with intermediate effect formoterol, or we can use aminophylline for injections. But exactly in intravenous injection, which is effective as broncholytic, we can cause stimulation of heart and the brain. That is why in intravenous introduction, we should introduce very slowly and exactly. Now, short break for 10 minutes. Let us continue our lecture. Let us continue. So, if the first group is the groups of drugs acting on bronchospasm, the second group eliminating bronchoobstruction. These are drugs acting on both and bronchospasm, on bronchial smooth muscle, and also on bronchial mucosa. The drugs eliminating edema and hypersecretion also. These drugs include specific anti-allergic, anti-inflammatory agents, stabilizers of mast cells membranes, antagonists of allergy and inflammation mediators, glucocorticoids, and combined drugs. Drugs, ready-made preparations, including 2 or 3 agents from different groups. Stabilizers of mast cell membranes. These agents decrease release of allergy mediators. That is why these are specific drugs used for allergic reactions of immediate type. Bronchial asthma belongs to this type of allergic reactions. We distinguish 2 subgroups: agents with local action and agents with systemic action. Local action, chemical name of subgroup chromones, include chromoglycic acid and nedochromyl sodium. Chromoglycic acid and nedochromyl sodium. These agents are introduced in the form of inhalation, and these agents have very poor bioavailability. That's why act only locally, act only on mucosa. That's why they can be effective only to prevent bronchial asthma attacks or acute reactions on pollens. And agent with systemic action, ketotifen. Mechanism of action is the same. They inhibit release of allergy mediators from mast cells, but preparation is used orally in the form of tablets. Bioavailability is relatively high. That is why preparation is absorbed in intestine and acts on the whole organism. That is why it can be used to prevent different allergic reactions of immediate type, including bronchial asthma. Antagonists of mediators of allergy and inflammation. They include following: inhibitors of phosphodiesterase 4. Phosphodiesterase is the family of enzymes. We distinguish several subtypes, 11 or 12 subtypes of phosphodiesterase. And PDE phosphodiesterase 4, this is an enzyme in the cells of lungs, of bronchi, of connective tissue of lungs. An inhibition of this enzyme causes inhibition of processes of allergy and inflammation. The agent is roflumilast. It's additional drug improving patient's condition suffering from bronchial asthma, roflumilast. Next, antagonists of leukotrienes. Leukotrienes, earlier we called these substances slow reacting substance of anaphylaxis, slow reacting substance. Nowadays we call it leukotrienes. Leukotrienes cause bronchoconstriction. One of effects of leukotrienes is bronchoconstriction. What is the origin of leukotrienes? Leukotrienes are produced from the cleavage, because of cleavage of arachidonic acid. Arachidonic acid is metabolite produced from membrane phospholipids. So in metabolism of phospholipids, all time membrane phospholipids are changed. Old phospholipids are destroyed because of influence of enzyme phospholipase A2 with formation of arachidonic acid and factor lysopef, platelet activating factor. And arachidonic acid after is cleft by two pathways. First pathway by COX cyclooxygenase and second pathway LOX lipooxygenase. Cyclooxygenase promotes cleavage of arachidonic acid with formation of endoperoxides, prostaglandins, thromboxanes, and lipooxygenase promote cleavage with synthesis of leukotrienes. But increase of leukotriene concentration provokes worsening of patient's condition suffering from bronchial asthma, because promote increase of tonicity of bronchi. That is why we use these drugs as additional drugs to treat bronchial asthma. And we use as the drugs of the first choice in special form of bronchial asthma, so-called aspirin asthma. Asthma provoked by usage of aspirin. We know that aspirin is a trade name of acetyl salicylic acid. Acetyl salicylic acid is well known non-opioid analgesic or non-steroidal anti-inflammatory agent. When we use acetyl salicylic acid, and not obligatory, not exactly this one, any of inhibitor of COX, if we inhibit COX using the drug, arachidonic acid is being transformed by LOX with increase of synthesis of leukotrienes. So usage of non-steroidal anti-inflammatory agents or non-opioid analgesics with the mechanism of action inhibition of COX can provoke increase of bronchial tonicity. And that is why, of course, we should use anti-leukotriene preparations. You see that we distinguish inhibitor of enzyme, lipooxygenase, xylitol. But more often we use antagonists of receptors, blockers of leukotriene receptors, zafirlukast, montelukast, pranlukast, ibudilast. Following. Antagonist of thromboxane. Thromboxane also provoke increase of bronchial smooth muscle tonicity. That's why sometimes we can use, to decrease synthesis of thromboxane, sulotroban. And monoclonal antibodies. These are specific antibodies against target molecules. Nowadays, we have specific immunoglobulins, specific antibodies against immunoglobulins E. Omalizumab. Omalizumab. This is monoclonal antibody. MAB means monoclonal antibody. Reslizumab, MAB, MAB, MAB. MAB always means monoclonal antibody. So these are monoclonal antibody against immunoglobulins E. That is why in severe bronchial asthma we introduce omalizumab, which binds to immunoglobulins E, that leads to improvement of patient's condition. Improvement of patient condition. We also use monoclonal antibodies to different cytokines, interleukin 5, reslizumab, mepolizumab, infliximab, tumor necrosis factor alpha, this is infliximab, tumor necrosis factor alpha and beta, etanercept, interleukin 13, lebrikizumab, tralokinumab, and interleukin 4 alpha, dupilumab. Monoclonal antibodies blocking these target molecules inhibit manifestations of allergic reaction and inflammatory reaction in bronchial asthma. Next, glucocorticoids. One of the most effective, the strongest agents with anti-inflammatory and anti-allergic activity are preparations of glucocorticoid hormones. We distinguish preparations of natural hormones, hydrocortisone acetate, hydrocortisone hemisuccinate, and synthetic analogs. Synthetic analogs include prednisolone, methylprednisolone, dexamethasone, triamcinolone. Both and natural and synthetic act on the whole organism. These are drugs introduced or intramuscularly or intravenously, and the drugs act systemically. These are very potent anti-allergic, anti-inflammatory agents, and they inhibit allergic reaction acting on both cells and also on antibodies, on different cytokines. More precisely, we will discuss with you in a few lectures. But these drugs are very potent anti-allergic, anti-inflammatory agent, but with additional broncholytic effect. But at the same time, they cause a lot of side effects associated with their hormonal activity. First of all, these are preparations of glucocorticoids. Glucocorticoids are a group of hormones of adrenal cortex. Glucocorticoids are counter-insulinic factors. They inhibit influence of insulin. That is why they cause increase of glucose level, so-called glucocorticoid steroidal diabetes. The increase of glucose level and glucosuria. It's first. Second, if less glucose enter the cells, muscle cell, hepatocytes, less glucose, this stimulates glyconeogenesis, because the cells need energy. Promotion of glyconeogenesis means amino acids are used for synthesis of energy instead of synthesis of proteins. So stimulation of glyconeogenesis causes inhibition of protein synthesis, and that is why inhibition, suppression of protein-dependent processes such as proliferation and regeneration. Regeneration, first of all, this can cause development of gastritis and ulcer of stomach with ulceric bleedings. Besides this, non-healing wounds in different areas, inhibition of proliferation causes inhibition of immunity, so-called immunodepressive effect, and both inhibition, and this is associated with anti-allergic activity, but at the same time, a patient starts to be sick with infectious diseases. Besides, the drugs have been glucocorticoids, they have partial activity of mineralocorticoids. That is why they provoke accumulation of sodium and water in the organism. It means edemas and arterial hypertension, but at the same time discharge of potassium, so they can cause hypokalemia, and discharge of calcium. In long taken, they cause development of a decrease of calcium concentration in bones, and so on, and so on. So, a lot of different side effects. That is why we use glucocorticoid preparations only in severe condition of the patients. But nowadays appeared glucocorticoids with local action, with local or topical glucocorticoids, which are of greatest importance nowadays, These are beclometazone, budesonide, flunizolide, fluticasone, mometazone, cyclizonide. These agents are derivatives of glucocorticoid hormones which are not absorbed through mucosa. They are used in the form of inhalation and act only on airways. That's why they don't cause systemic effects, but they are very effective as anti-inflammatory, anti-allergic, and nowadays usage of topical glucocorticoids is very helpful for treatment of bronchial asthma. Combined drugs. These are ready-made drugs containing several agents. Theophylline plus ephedrine, phenytoral plus ipratropium bromide. These are all the drugs. Phenytoral beta-2 adrenomimetic. Ipratropium is topical M-colon blocker. Phenytoral chromalin nitrate, salbutamol chromalin nitrate, salmeterol fluticasone, formoterol budesonide. These are examples of beta-2 adrenomimetic combined with topical glucocorticoid. These drugs, ready-made drugs, also are very popular. And the latest, which are the most effective, vilanterol, umeclidinium bromide. Vilanterol is long-acting beta-2 adrenomimetic, umeclidinium long-acting topical M-colon blocker. Same indacaterol plus glycopyrronium. different representatives, but two mechanisms. Olodaterol plus tiotropium bromide, third sample of this combination. And very effective is vilanterol plus fluticasone. Vilanterol is long-acting beta-2 adrenomimetic, fluticasone is topical glucocorticoid. So these combinations are very effective and very popular nowadays. For today, we will finish the lecture. You may be free. Goodbye.